We're here with Andrew Phillips from the University College London, and we're going to be talking to him about the findings that you took from the START, a nested trial within the START trial, and it was in cardiovascular risk and lipids. And let's let you set us up on that, if you will.
Yeah, I mean, the SMART trial randomized 5,500 people with CD4 counts above 350. Most of them were on antiretroviral therapy, but not all. And they were randomized to either continuous ART therapy or to episodic use of ART therapy based on the CD4 count. So when their CD4 count was above 350, they would actually interrupt antiretroviral therapy. When the CD4 count had fallen below 250, they would restart antiretroviral therapy. So for those on therapy at baseline, they interrupted antiretroviral therapy if they were randomized to that episodic arm, whilst for the ones on therapy at baseline, if they were randomized to continuous therapy, they would start therapy, and the other group just stayed off therapy. The main findings of the trial were to compare the opportunistic disease and death between the two arms, and the episodic arm of the trial was stopped in early January 2006 because of a much higher rate of AIDS and death in the episodic arm. But our focus was on the cardiovascular risk in the two arms. And it had been hypothesized that those interrupting antiretroviral therapy would have less cardiovascular events because of the association between antiretroviral therapy and cardiovascular risk that had been identified in cohort studies. But in fact, we found a borderline statistically significant raised risk in those that were interrupting therapy that were taking less antiretroviral therapy. And so I conducted a series of analyses to try and understand more about that, including looking at lipid changes between baseline and one year. The main findings in terms of cardiovascular risk were that we couldn't find a clear association with increased viral load levels. That didn't seem to be associated with increased cardiovascular risk in the patients that were interrupting. We couldn't find an association with CD4 count such that lower CD4 count was associated with more risk of cardiovascular risk. And we also, if you just looked at the group of patients who were on that interruption episodic arm, they actually experienced, if anything, slightly higher risk during periods they were on therapy rather than periods when they were off. So none of that really was consistent with the idea that there's an immediate increased risk of cardiovascular disease directly as a consequence of stopping therapy. So we didn't feel there was any evidence for that. The other issue we looked at was lipid changes, and in particular cholesterol changes. And here we found that the episodic arm, their cholesterol levels decreased as a result of stopping antiretroviral therapy, as we had expected given the fact that total cholesterol levels go up with antiretroviral therapy. But also there was that was potentially something favoring interrupting therapy because total cholesterol levels were lower. But we also looked at HDL cholesterol levels, for which higher levels of HDL are better, and we found that declined as well in the patients interrupting therapy. Again, probably as a result of the fact that many drugs raise HDL cholesterol. And so we had two potentially conflicting things going on with a beneficial effect with total cholesterol being lowered in those interrupting, but a negative effect because HDL cholesterol was being lowered. And when we tried to look at the balance of those two things to see what the net effect would be, it turns out that the interrupting actually seems to have a net negative effect on the lipid profile. So that's one potential explanation as to why interrupting leads to raised risk of cardiovascular disease, but that's really only a very tentative explanation at this stage. And in terms of the overall clinical message, really it's just one simple message, which is that there should be no reason to avoid or to stop antiretroviral therapy because of concern about cardiovascular risk.
It wasn't a demonstrated difference enough that you would say that you could really make that concern?
No, I mean quite the reverse. If anything, even though we don't understand it, if anything, those remaining on therapy have a lower risk of cardiovascular disease. Those stopping have a higher risk, and we don't really understand it, and it may not be real, but certainly we couldn't find any evidence to suggest that you should you should be stopping antiretroviral therapy to prevent coronary events.
That wouldn't be a reason to do it. So I know that you only want to really speak about this issue, but how does that? Can you give us a sense of how that fits into what we've already known? And I mean, kind of what we've already known led to some of the the design of this trial, probably.
Well, I mean, what we've known so far has really come from cohort studies, and they've been relatively mixed. But most prominently, they've really shown that the increased exposure to protease inhibitor drugs, cumulative exposure to protease inhibitor drugs, shows increased risk of cardiovascular disease. We were looking at something fairly different, looking at interrupting of antiretroviral therapy. There certainly haven't been many randomized trials which have actually looked in HIV infection that have looked at incidence of coronary heart disease, of cardiovascular events. And so there's not really a great deal to compare our result with, because there are no other equivalent studies to which we can, to put into that context.
So the SMART trial is stopped early, and now we'll probably hear more data down the line on this.
Yeah, the patients are being followed. Even those on the episodic arm are recommended to go back on therapy in January 2006. 18 months more follow-up is being carried out on the patients, and so we will have some more data, but many of those patients have gone back onto antiretroviral therapy.
So that may skew the data somewhat? Or?
Well, it certainly won't make it such a clean comparison as it is at the moment, but given the limited number of events we've got at the moment, I think that it will certainly help us to understand more about what's going on.
Great. Well, I appreciate very much your taking the time to represent this to us and to kind of clarify that there is really, it still is not a profound issue. It's not something where people are really seeing one way or the other, I guess, but it's certainly worth keeping the information coming, and we're glad that this trial was at least answered. Some of the questions were answered, because we were sort of disappointed in the trial stopping in the first place, the SMART trial, but I'm sure this is something we'll be seeing more about. There's other nested studies, I guess, that are still finishing up.
Yeah, there are.
So very good. I thank you very much, Andrew.
Okay,
Yeah.
thank you.
And if you want to do